its children home.
All right, I can't do this thing without going through a little anatomy. So basically, in the upper extremity, there are two main systems: the cephalic vein on the thumb side and the basilic vein on the ulnar side. And these travel up the arm, and they'll join up at the axillary vein. So the axillary vein is the continuation of the basilic vein in the arm, and it travels up in the deltopectoral groove. And the cephalic will come in. I'll show it on the next slide. Okay, so here we see the basilic vein, the brachial veins join it to form the axillary vein, and here we have the cephalic. This is the arch of the cephalic, and it joins right before the first rib, and it joins the axillary vein. The cephalic vein will join the axillary vein. So here's another patient. You can see the cephalic vein coming up very superficial, and it joins in here, and you can see the basilic vein coming up under the pectoralis minor muscle, and they'll join up. And the dividing line is the axillary vein becomes a subclavian at the lateral border of the first rib. Here is the axillary vein entering the deltopectoral groove, and here it's axillary vein, axillary vein, axillary vein. Not till it gets to the lateral border of the first rib and starts ducking into the clavicle does it become the subclavian vein. When you put an ultrasound in this area, you're looking at the axillary vein. And here's another diagram that shows the anatomy as well.
Okay, so we're going to demonstrate vascular anatomy in this subject. What we can see here is the axillary vein coming up from the arm, entering the deltopectoral groove. So it's all axillary vein here, axillary vein, axillary vein. When it gets to the lateral border of the first rib, this becomes a subclavian vein, which ducts underneath the clavicle. The jugular vein comes down, ascends to the neck, and it joins with the subclavian vein just north of the sternoclavicular joint to form the brachiocephalic. Of course, the two brachiocephalics will join to form the vena cava. In addition to this, we have the cephalic vein, which runs superficial to the pectoralis minor muscle, and then joins up with the axillary vein just before it becomes a subclavian.
Sometimes you need the guy with the right tattoo to help you out. So all those veins are cannulatable except for the cava. Probably IRs figured out how to cannulate the vena cava. The cephalic vein was my contribution to the world literature, but I took those papers out because it's more of a fringe thing. And again, this is the anatomy that when you put an ultrasound in the infraclavicular fossa, you're visualizing the axillary vein. Radiographically, it's good. I mean, it takes a little bit to study this. But it shows the different shadows that indicate the different vessels and their relationships, and every time I look at it, I learn something new. So here's a patient, very lean patient, where you can actually see her axillary vein and artery traveling up.
This patient is going to require central venous catheter for pressors and intensive care unit purposes. So we're going to attempt to insert a right axillary vein catheter. We can actually see this lady. We can see her vessels going from the deltopectoral fold under the clavicle. So we can see her artery and her vein, and the artery is superior and the vein is inferior. It's rare that you see this, but in this lady you can see it really quite well, especially as she breathes up.
So when you put an ultrasound in that area on somebody, this is the anatomy that you'll see here. So this is the second rib, and the pleura is down here, axillary vein, axillary artery. The vein will always be toward the feet if you have the probe aligned properly. So that's what you see there, and it's not the subclavian vein. In venography, the same thing. You can see, you get a nice look. Here's the cephalic vein coming in to enter the axillary vein right before it becomes the subclavian. The borderline is the lateral border of the first rib, and then it turns down into the brachiocephalic, and you see the jugular coming in up there. This diagram speaks to me a lot. So you're going from the arm. So the axillary vein, a lot of veins say like the femoral just stays in the lower extremity, but the axillary vein goes from the arm to the chest. So it gets a little complex, the ligaments and muscles of the shoulder and the chest muscles, that sort of thing, So here's a question that I was, where does the subclavian vein live? And the subclavian vein lives in the bony tunnel bordered by the clavicle above and the first rib below. I say, so how do I know that? I memorize it. I heard it so many times that I memorized this silly thing, But I'm going to show it to you now in this cadaver dissection, the bony tunnel. So that is a PICC line that's in the axillary vein that's been dissected. And you can see up here the bony tunnel. When you stick it blindly, you're trying to get your needle into that bony tunnel. I certainly never saw a dissection in a live patient. And you can see even with that amount of dissection, retracting the sternum, you don't even see the subclavian vein. This is the first paper that described the ultrasound-guided cannulation of the subclavian vein by a lady named Emily Gualtieri from Pittsburgh. And you can see from her diagram, she's puncturing the axillary vein, but the title of the paper was subclavian venous access, so they kind of got it wrong. And what's the big deal on this? You know, like, for the surgeons in the room, who wants to expose the subclavian vein? Where if you can expose the axillary vein, you know, you're a lot better off. That subclavian exposure is ridiculous, you know. Again, we're coming up from the arm, and just shows that it's the axillary vein until it gets to the lateral border of the first rib. And I actually wrote a paper on this, and I submitted it to Critical Care Medicine, and two of the reviewers accepted it, and two of them rejected it, and was finally rejected. And my point basically is, you can call that catheter a subclavian vein catheter all you want, and it's not. It's in the axillary vein. It's 8 centimeters from the subclavian vein, the lateral border of the first rib. So clearly an axillary vein catheter. And here's a patient that somebody had a blind subclavian here. You can see how close it is to the sternum, and whereas if you're cannulating his axillary vein, you can see how far out from the sternum that it is there. All right.
Okay. So the clavicle is lying up here, and we've marked on this thin patient the first rib and the second rib. And we believe that if we puncture the axillary vein going fairly steeply lateral to the second rib, that will be outside of the lung field. As you can see, I'm clearly lateral to the second rib and focus on the steepness of the angle of penetration. Okay, so here we can plainly see that the catheter entrance is in the axillary vein lateral to the second rib.
So it's an older procedure. There's sutures in there. I certainly don't suture anymore. I don't use the needle guide thing anymore. And I'd say that's my go-to line in the intensive care unit, the axillary vein, unless there's some reason not to do it. So moving on, we're going to talk about the neck a little bit, external jugular, internal jugular, brachiocephalic. So here's a patient that's got, prominent external jugular veins.
Sternal head and the clavicular head of the sternocleidomastoid. You see an external jugular crossing, and we also see this big posterior jugular vein here. So it's a nice demonstration of the venous anatomy back there. We're probably going to go in this area, in the low in the clavicular area. Because of these veins, normally we would puncture right about here, but we're going to have to go in the more in the anterior aspect in order to avoid these large neck veins, which we can see. So we're going to go right in the heads of between the heads of the sternocleidomastoid muscle. Really here in the neck. Now, once we get in the vein, we're going to have to rotate it.
So once I'm in the vein, I had to rotate it more cephalad so that the wire would go down. But just the kind of things that you look at. Here's a patient of a venogram, patient with bilateral thoracic outlet. There's a lot of anatomy in here, and you see when he raises his arms, the flow of blood shuts off in the veins pretty much. So I guess thoracic outlet's a real thing. All right, so moving on, into the neck.
No, I said no, you're not the one for me.
I'll play that again later. Let's see. Anybody tell me what that, so this is the internal jugular vein. Anybody tell me what that vein is? Anatomy question? Right, that's the common facial vein. The vagus nerve is over there. Okay, cool. The brachiocephalic, the junction of the subclavian and the internal jugular vein. That's a great vein. I love to puncture the brachiocephalic, especially for dialysis catheters. It's basically like a low jugular puncture. And this is what the, this is what the brachiocephalic will look like. I think that's actually my son's brachiocephalic vein, if you can get a look like, and that's one of the things we'll teach in the receiver protocol. And here's cannulation of a brachiocephalic. So I've marked out the jugular vein and the subclavian, supraclavicular.
Joint, and likewise, we trace the subclavian vein in the supraclavicular position toward the sternoclavicular joint, indicating the brachiocephalic vein where the two veins join up.
Going around the sternoclavicular joint, the subclavian's joining the internal jugular.
Skin. I definitely prefer not to nick the skin. Okay, so you see some wire coming out. Right on top of the clavicle.
So I want to dress downward, and we'll certainly discuss that a little bit more. So moving on, and I added this section into the anatomy section, tip location. At Jersey Shore, there's something wrong. There's something wrong. I reviewed a bunch of x-rays when I came here. Everybody seems to know that the tip of the catheter is supposed to be down near the cavo-atrial junction, but if it's not, nothing's done about it. The radiology department here, I don't know what to say. I've discussed it with the chief of radiology briefly, but they're not really offering much help in their x-ray reports. But if you're in vascular access, tip location is a cardinal thing. That tip has to be down near the cavo-atrial junction, and I'll go into why. So, that shows the, I like that. It shows the tip right above the atrial appendage. So, is catheter-related central venous thrombosis important? What is the number one factor associated with catheter-related central venous thrombosis? Somebody tell me, what is the number one factor? So I asked the question, I usually direct that at my anesthesia colleagues, that it's a tip that's too high. It's a tip that's too high above the cavo-atrial junction. I'll show you some studies in a second. But I usually put in, if somebody doesn't know this, should you be allowed to do this procedure? If you don't know the leading cause of that morbidity, should you be allowed to do this procedure? It's questionable. And so what are the acceptable locations? The acceptable locations coming from, the upper extremity or the neck is the cavo-atrial junction, the distal third of the superior vena cava, and the upper right atrium. This is Scott Treritoli. He's the chief of IR at University of Pennsylvania.
Much more morbidity occurs due to high catheter tip position and the fear of putting the catheter too low than putting the catheter too low, okay? There is so little evidence that low catheter position causes any morbidity at all. And
I agree with him. He's been one of the instructors for me. So this is, when I reviewed x-ray, this is from my own files, but when I reviewed x-rays here, we found some like this. So basically, this is a left chest line that comes across into the brachiocephalic, and it's jutting into the wall of the vena cava. It doesn't make the turn down. In this hospital, you only have a 20-centimeter catheter, so it's not long enough. Dr. Treritoli would call this dangerous. In his report, this would be dangerous. And if it came up in the second day and it wasn't fixed, he would call you and let you know about this. You cannot tolerate catheters that are in this position. All right, somebody take a look at this, interpret that x-ray for me. So here's it's a tunneled IJ catheter, and the tip of the catheter winds up here. Anybody? I would call that mid-SVC position, okay? The nurse called me the day after it was put in, the patient was an inpatient, and said it wasn't aspirating blood. So what do you do for something like that? I could have squirted in some alteplase, and I'm sure that I could have gotten that catheter working. I took the patient back to the endovascular lab, and I revised it, because it's not in the right spot. It needs to be down here. It's about 4 centimeters short. Sure, I believe the TPA would have worked, but that wouldn't have been the right answer. That was my patient. Why I got it so wrong, I don't know. I had fluoro, maybe, human error. We're all fallible human beings. Okay. This is the evidence supporting why the catheter has to be down at the cavoatrial junction, okay? This is Puel, so it shows as the catheter gets up near the junction of the brachiocephalix, the rate of DVT goes up to about 28%. In this paper, it's 79%. And then you can see in this one, this is good, I like this, like 86% deep vein thrombosis, and it's silent. A lot of times, the problem is it's silent. And then the patient comes in later with this superior vena cava syndrome or, that kind of stuff. But as you go down, it's 31% here, 16%, 14%, 1.2% if you get down at the down inside the cavoatrial junction. So the line really has to be down in the right spot. There's another catheter that shows the same thing, that the higher you get above the cavoatrial junction, the higher the deep vein thrombosis rate. So two things happen if the catheter is not in the right spot. They don't function as well, and the risk of deep vein thrombosis goes way up, right? So I'm going to talk about EKG-based tip location of the catheters. And so one of the things that I've asked a couple of times, what is the cost of a chest x-ray in this institution? And that'll be important, for me to know. Why don't MDs in the United States use EKG-based tip location? Somebody tell me. Somebody tell me why they don't use it. So when I asked this question in Florida, the chief of critical care told me he'd never heard of it. I'm going, well, that was honest. If you never heard of it, you wouldn't use it, right? But it's clinically better than chest x-ray, primarily because you're doing it during the procedure. Like if you get an x-ray afterwards and it shows malposition, okay, you bless it. You tell the nurse, you can use it. Sure, you know what I mean? The trick is during the procedure to find out if it's going properly or improperly, so you have a chance to fix it, With this technique, you don't need a radiology technician. You don't need a portable x-ray machine. It's cheaper. So it's better and cheaper, and I'll get into that. Your RNs are using it with their picks. So like the RNs have a more sophisticated way, but why didn't we learn it? Why didn't we learn to do what they're doing? And then you do the sliding lung to rule out pneumothorax, and we'll demonstrate that in the simulation. All right, cost effectiveness. Cost effectiveness, is this term that's thrown around. We all kind of know what it means, but is there math behind it? Like I never understood it. So this is the best. This is a health economist from Australia that explained it to me this way, that on the x-axis, you have the effectiveness, clinical effectiveness. So from left to right. So it goes, more clinically effective as you go to the right. The y-axis is cost. As you go up, things become more expensive, right? So the way this works, you have 4 quadrants. In the left upper quadrant, you'll have something that doesn't work as well, but is more expensive. If somebody comes to you and that's their pitch, don't get that one. In the left lower quadrant is something that doesn't work as well, but you save a few bucks. Usually we don't go in that direction either. The right upper quadrant is where we usually live. Some rep is going to come to you with the greatest thing, but you have to pay more for it. That's where we get supply chain to help us figure out, is the juice worth the squeeze? You know what I mean? It's probably above our pay grade. In the right lower quadrant is something that's clinically better and you save resources. It's rare. When somebody comes to me with that, I don't stop till I get it because it's irrational not to do it. This EKG-based tip location is in the right lower quadrant. If you don't use it, one of us is irrational. All right. So basically, suppose there was a method to determine the location of the catheter tip. Did not require an x-ray machine, clinically better, and cost less. You'd probably adopt it. So here's how it works. Pacemaker of the heart is the sinoatrial node, as you know better than I do. It's thought to be at the junction of the superior vena cava and the right atrium. In this pictogram, it's here. I've been in the heart surgery, and the cardiac fellow's like, oh yeah, yep, and I'm looking. I don't think anybody's ever seen the SA node with their eye. You know what I mean? Like, but that's where it's taught to be, at the junction of the superior vena cava and the right atrium. And with the Einthoven triangle, you have the leads on. The electrical generator is the heart, and it's in the center of the chest. But the sensor in lead 2 is down here on the upper thigh or the lower abdomen, like 20 centimeters away. And because of that, you get this, standard EKG, small P wave, atrial musculature, large QRS, ventricular musculature, right? But suppose we put the sensor at the cavoatrial junction, inside the catheter. What do you think would happen to the P wave when you got down to the cavoatrial junction? Yes, it becomes a monster. Here you have the P wave is larger than the QRS because the sensor is right at it's not on the thigh, it's right at the cavoatrial junction, right? So here's an explanation of it, a pictogram I'm going to show you in a second. So I got to go back. All right, in the first one, you can see the catheter is coming down. It's like in the middle of the SVC where my catheter was in that one. And you see that you can pick up a prominent P wave. As you go down further, as you get down to the cavoatrial junction, you get a large P wave and there's no negative deflection. This is called P max. We're looking for P max. As you go past the cavoatrial junction, you're going to get a negative deflection in the P wave. And it tells you that you've gone a little bit past the SA node. Now, with the patient supine, that's what I like. It's a little too much in the weeds there. And as you go further, the P wave will become biphasic because you're so far past the SA node. And you'll see all these changes with inside like 3 or 4 centimeters. For example, pay attention to the P wave with those changes I've just explained, okay?
We're going to talk about EKG guidance of the catheter. So I estimate from the left axillary position that he's going to be about 28 centimeters down to the cavoatrial junction. We're going to remove the inner cannula and the wire.
I'm going to replay that. Suppose I wanted to put in a 28 centimeter catheter in this institution. What would you give me?
20.
Yeah, so it's going to be sticking into the wall. I'm going to play that again, but pay attention to the P wave.
We're going to talk about EKG guidance of the catheter. So I estimate from the left axillary position that he's going to be about 28 centimeters down to the cavoatrial junction. We're going to remove the inner cannula and the wire.
My catheter has the wire
Now we're gonna
sticking out.
insert
That's the sensor.
Our catheter.
You can use
with the
saline
guide
column
wire.
or
It's gonna
a
attach
metal
the
wire.
alligator clip to the wire that's inside the catheter. We're at about 21 centimeters. We see a prominent P wave. I'm into 23 centimeters, and you can see the P wave enlarging. So we know that we're heading down toward the SA node. All right, 26 centimeters, we see an even larger P. Then we go to 27. At 27, we see the first appearance of the deep negative spike. So 26, we had a very large P wave. At 27, we had a very large negative spike. At 28, the spike becomes even larger, the negative spike. Now we're at 29, and now we see a change. The P wave is not as large as it was at 29 centimeters. It's still a negative spike. We're going to pull back out to the 27, which coincided with our measurement. 27 centimeters to the SA node, and we're going to get the chest X-ray in this position.
And you can see I'm down here, right down here near what I would consider to be cavoatrial junction on that read. Now, so chest X-ray versus EKG, right? It's clinically better because you can tell during the procedure if you've gone correctly, or more importantly, if you've gone incorrectly, you have a chance to fix it. Cheaper, no radiation. Your RNs are using it. We got to learn from the different people. Learn from IR, learn from the RNs. They're using it. It's a better way to do it. So why aren't MDs using it? Don't answer that. So the other thing, yes, ma'am.
Sorry. What if your patient's in atrial fibrillation?
Great question. Great question. So Atrial fib. If the patient's in atrial fib, well, you don't have a good P wave. So, or pacemaker, or pacemaker. Now, it's hard to use it. The F waves for the fibrillation, you can use it when they become maximal. And there's a system coming out that will read that with a computer for you. So, but you're right, that is a kind of a contraindication, the atrial fib, when you get started. Okay, excellent. Okay, then the other thing is, you guys all know about sliding lung, right? Yes, you know about sliding lung. So that's what people say. Well, what about, ruling out pneumothorax? So
a EKG method or an algorithm-based technology or an EKG and Doppler technology. So in many cases, we don't need a chest x-ray to tell us where the tip is. So regarding pneumothorax, we don't really need the chest x-ray for that either, because with the ultrasound, we can rule out a pneumothorax in better fashion than with a chest x-ray. And the way we do this is we take the ultrasound probe. So basically, we're going to put the ultrasound probe parallel to the sternum in the upper chest, and I've marked out the area where this is. And we're going to put this in, and we're going to watch the patient. We can see the pleura, the visceral pleura sliding against the parietal pleura, and we can see some nice vertical comet tails. When you see this, you do not have a pneumothorax. So we're going to repeat this after the procedure. Okay. So as you can see, this lady axillary central venous catheter placed, and we're going to make sure that her sliding lung hasn't changed any. So we're going to put the probe in the area parallel to the sternum, just to the right of the sternum. And we're going to see if we have a sliding. So I'm going to ask you to push that button, and we can see some nice clip button. Good.
they're not always as prominent
See those
as that.
vertical tails? Those are called comet tails. Okay, so then, better than a chest x-ray, the sliding pleura sign should demonstrate that there is no pneumothorax. Thank you. In contradistinction to the patients that have a positive sliding lung, some patients with severe pulmonary pathology or pneumothorax will not exhibit a positive sliding lung sign. This is an example of a patient of what absent sliding lung looks like, and here's the x-ray to explain why she doesn't show a sliding lung sign.
You wouldn't expect normal pleural dynamics from that little scene there, but it's the greatest, so when I came here, I said, if I brought the greatest thing, and I believe the EKG thing is the greatest thing for what I've said already, what would I have to do? Go to 4 departments like anesthesia, critical care, surgery, and the ED, and pitch it to all 4 departments? They said, no, you have to pitch it to the whole 10 hospital system. So I'm saying, that says to me, never. That means we're never going to get this thing. That's the greatest thing. So that's how you don't advance. Keep putting up hurdles, but that's where we are. All right, femoral is a thing now. In this hospital, people are upset that the femoral is overused, and I think we're going to try to change the femoral overuse, but we're going to also make using the femoral better. So we all know this anatomy here: nerve, artery, vein, lymphatic, empty space, all this cool stuff. But you can see that in the groin, the vessels are side by side, okay? And here's an ultrasound. So before we do anything, the vessels are side by side, the artery and the vein. But as you go down the leg with the ultrasound, and I thought this was an anomaly, but this is what happens. The femoral vein slides under the femoral artery as you go down the adductor canal. So it becomes a little more challenging, as you get, outside of the groin. So there's a thing called the zone insertion method. It was made for PICCs. So for PICCs, you don't put PICCs by the elbow and you don't put them near the arm. You put them in the middle of the arm. Why? That's where they belong. So there's no flexion. The same thing for the neck and the groin and the femoral. We don't want the femorals in the groin. We want them in the leg. So there are basically 2 ways. Puncture the femoral vein in the middle of the thigh, or puncture in the groin and then tunnel it out. And it's not a difficult thing. So this is a nurse practitioner up in Patterson. This is how he does it. It's nowhere near the groin. It's way out of the groin. He's got it way down there.